All right. So we should be done. Hopefully we'll wrap up a little early today for you guys to get the rest of the day on the way. So yesterday we stopped basically with, I'm gonna go back, with ovulation, right? So essentially the mature follicle was released from what is actually technically known as the antral follicle. So the mature follicle is released out, that is ovulation. So now we are here, okay? And as we have discussed, the ovary is not physically attached to the fallopian tubes or the uterus. There's just ligamentous attachments that hold it in place near the opening of the fallopian tube. So we have to get that egg, that oocyte that has been released essentially into the pelvic or peritoneal cavity into the fallopian tubes. And how does that occur? Currents produced by the fimbriae, those little fingers that are the opening of the fallopian tube, literally wave it and produce currents that bring it into the tube, okay? Now that is critical, of course, like I said, because if that doesn't happen, there is a potential for fertilization outside of the tube. If you have some really persistent sperm cells, can make it all the way out there and literally fertilize the egg outside. So it's very important because the majority of the time, the most common place for fertilization to occur and the most efficient place for it to occur is in the ampulla of the fallopian tube. We'll talk about where that exactly is in just a second. But not only is it, once we get the oocyte into the fallopian tube, we still need to move it down, right? It's the physiology of it, is that the sperm are swimming up towards it, the egg is being moved down to be able to meet at the appropriate place. So the peristalsis of the actual fallopian tube brings it proximally, or moves it distally down, into the fallopian tubes, all right? If it doesn't happen, if no sperm meet it and fertilize it, by the time it makes it to the uterus, then that oocyte disintegrates, the hormonal changes start to occur, and then menstruation happens, all right? And that is what we're gonna talk about the next block, the full reproductive cycle, about what happens if no fertilization happens, and if fertilization does occur, okay? Let's say right now it does occur. This is the most common spot, the ampulla of the fallopian tube, sort of like the middle part. So if you can imagine, if you have the picture on the next slide, but you imagine the fimbriae and sort of the arms move up over and connect into the uterus. The ampulla is sort of that upper curved portion. That is where fertilization will occur most of the time, all right? And then we discussed this already. As we have fertilization, we have two haploid cells that meet. Once the zygote forms, don't forget there is also that second polar body that's formed of discarded material. But the larger cell and the sperm cell meet, unite, the sperm acrosomal reaction penetrates the zona pellucida, and now we have the delivery of the genetic material, and we have now a zygote, okay? It begins, this is a pretty important part as well, cellular differentiation in the zygote begins before actual implantation. Okay, so before it actually implants into the uterine wall, it's already starting to multiply, work its way towards becoming a fetus. All right, so this is the ampulla right here, like I said, sort of this curved portion. This is the fimbriae, or these are the fimbriae that sort of wave that into the opening of the fallopian tube, and then this is the most common portion, and then as those peristaltic waves continue, the zygote should continue down and then ultimately implant somewhere in the uterine wall, okay? If you look here, we're going to talk about this again. Anything having to do with salpinx, salpingo, that prefix, that has to do with the fallopian tube. So you don't need to know the individual portions of the broad ligament, but if you're looking at it, what does that exactly mean? Mesosalpingex means essentially it's this part of the broad ligament that sort of fixes the fallopian tube into place, all right? So just in case you know what the salpinx prefix means and you see it later on, you will, okay? Just a quick clinical correlation, as I said, one ovary releases one mature grafting follicle. That is what should happen. If anything goes wrong and there is a second ova that is ovulated, then you can end up with fraternal twins. Dizygotic twins means two zygotes, right? If it's monozygotic twins, meaning identical twins, that means that one ova that was fertilized now splits into two distinct zygotes. That's how so that's the differentiation between the two types of twins. Okay? Alright. Any questions about ovulation, like that whole process of follicular development, anything that's not sort of clear? It's just a matter of looking at it over, a couple of times and getting it under control, but it's really not that complex up to now. We'll add a deeper dive, like I said, on the next time we meet. But any questions? Okay. So now let's talk about the actual uterus. All right, we'll talk about what position is normal. And there are multiple positions for the uterus, okay? So, normally sitting right here on top of the urinary bladder, which explains why there's so many problems with urination, having to pee all the time when there's a baby in there sitting on it, okay? And I'm not going to outline all of the structures here, but you see this is the normal position of the uterus, sort of leaning forward, right? And this axis, this is the vaginal canal, so this is the normal axis of the uterus as it relates to the vagina. So it's sort of leaning forward and bent forward, okay? And that's what this means. So the typical position is anteverted and anteflex. Now what do those two words mean? The anteversion means the forward tilt. So you see that this is the angle of anteversion here. And you see that blue line that says axis of the vagina. And you see how it intersects with the axis of the uterine body. That is, this right here is the angle of anteversion. So in reference to the cervix, does that make sense? See how the cervix is pointed sort of backwards and down, the vagina is pointed like backwards and up, all right? And of course this is anterior, right? This is anterior right here. And then you have the axis of the uterine body, and you have the axis of the cervix again. And this is the degree of anteflexion. So anteversion is tilted forward, anteflexion is bent forward. Does that make sense? Is that an easier way to say it to you guys? You can measure these angles with radiography, but does that make sense? And if it doesn't, if the angles don't necessarily make sense, I just want you to understand what the words mean. The word anteflex means bent forward, word anteverted means tilted forward. And that's the normal position of a woman's uterus, all right? Now, just to contrast that between this is anteverted, so it's tilted forward, but it's not bent, right? This is retroverted, so it's actually tilted backwards. This is anteflex, but not anteverted, so you see how it's just sort of like curved over instead of being tilted forward and curved over. And this is retroflex, so it's just tilted backwards. And all of that is important. Why is any of that important? One, because of difficulties potentially with pregnancy, but also you as a primary care provider, when you go and you do a speculum exam, you're expecting the cervix to be posterior and inferior, and if it's not, that could mean position of the uterus is altered, so you have to go and look. It's not uncommon for you to put the speculum where you think the cervix is supposed to be, and it's not there. Then you start sweating, then you gotta find it. You know why? Because it's not a comfortable exam, and so you need to find the cervix as fast as you can, but typically what you do is you place the speculum and you go inferior and posterior, and it should trap and be right there. And if it's not, it means probably the cervix is tilted and pointed in a different direction because of a difference of actual anatomic placement of that patient's uterus, okay? So that's why it's kind of important. Does that make sense to everybody? Yes, sir.
With the patient often, because they probably get these a lot throughout, especially if they're older,
they will know probably, yeah. So I'll tell you this. So when you guys do what's called the RTA lab, you have female patients and male patients. You'll practice the speculum exam, then you'll practice the genitalia and rectal exam on a male patient. The women who come and do this, they do it all the time. They do it at multiple different universities and institutions, and they are well aware of, sometimes, I'm not kidding you guys, it sounds like I'm joking, they will let you mess up just so you can experience the fact that they're their cervix isn't where it's supposed to be, and then they'll say, I told it's not, it's actually my uterus is retroflex. Because they're just really dedicated to women's health, and they want you to get a mistake under your belt with them and not with a real patient. But yeah, most women in a normal patient care setting, if they've had they're coming for their second or their third half or what have you, they will usually know that their cervix isn't where they'll say my cervix is hard to find or something like that. And that'll kind of give you a clue that it's not necessarily where it's supposed to be right away. All right, does that make sense, everybody? Any other questions? Yes.
In like retroflexion, for example, will the woman have like bowel issues and it's like pushing on its own?
Potentially, but not. I mean, potentially when they're pairs, if they're gravid, if they're pregnant, then they could potentially have some constipation issues. Yes, but in most cases, not really. You know what I mean? It's a lot of times it's not necessarily that dramatic, but if there's nothing in the uterus, right? No baby in the uterus, it really doesn't cause that much of a problem. The bulk of the feces will be able to sort of maneuver around it. But it's a potential, yeah. Anybody else? Yeah.
Say like a C-section where they cut open the uterus, or say deflex, would it shift the way it's?
No, if it's
something like
because the musculature is going to be like they can't move it into normal position unless they were to tack it down. And eventually, it's going to find the way that it was developed. You know what I mean? Does that make sense? I mean, a C-section is one thing. Like wherever the uterus is, when it's open, you know, you'll grab, you know, the uterus is right there. You can get it, but it's going to have a tendency to go back to where it was in the first place. All right, and there's really, unless the patient has some sort of odd pathophysiology, it really doesn't matter. You know what I mean? So, does that make sense to you? Yeah. Anybody else? Okay. All right. So those are the positions of the uterus. Let's talk about the actual anatomy of the uterus itself. So the uterine fundus, okay? Uterine body, right? That is what is measured. The top of the fundus is what you measure when you go into your well woman exam. Anybody who's been pregnant before, they measure the top of the fundus to see approximately what week of gestation, okay? The body is the middle. Cervix, we're going to talk about distinctly, even though it is a portion of the uterus, all right? And let me go back to this. The cervical canal and the distinction between the internal and external os, all right? So the external os, if you're doing a speculum exam, the external os is what you're seeing. That little hole in the middle of the cervix is the external os. The internal os is the opening from the cervical canal into the actual uterine cavity, all right? So the external is external, the internal is internal. Sometimes people get those flipped around, I'm not really sure why, but I just want to make sure that you guys understand that, okay? What you're visualizing on a pap smear or a speculum exam is the external os, okay? So looking at this, and just to make that point, the external os again here, this is the vaginal cavity, right? This is exterior. You're looking at the external os, and then the internal os is here at the end of the cervical canal opening into the uterine cavity, okay? The fundus, again, as this grows with a gravid uterus, that's what's measured at the top. So you measure to the top of the fundus, and you can approximate weeks of gestation, okay? Layers, histologically, again, perimetrium is sort of the outside, or on outside in the myometrium muscle, as you can imagine, layers of smooth muscle. This has a huge role in contraction and getting the baby out, expulsion of the fetus, okay? And then endometrium, many of you are probably familiar with the term endometriosis, right? So the endometrium, the inner lining of the uterine cavity, the two different layers, the stratum functionalis, the easiest way to think of the word functional, it's the one that moves and does stuff. That's what sloughs off with menstruation. And the stratum basalis is the basal layer that is always there. That does not come off during menstruation, okay, after a lack of fertilization. But the endometrium, endometriosis, just briefly what that is endometrial tissue that is growing somewhere else where it doesn't belong. The precise etiology of that's not really known, but it can grow into the it can grow anywhere outside the pelvic cavity, on the intestines, on the bladder, on the fallopian tubes, on the ovaries, and is associated with a high degree of pelvic pain for that patient. It's a can be crippling disability, ultimately leading potentially to full hysterectomy, meaning taking out the uterus, just because of the inability to control that patient's pain. Okay. Also leads to fertility issues. So looking at the peritoneal pouches, why is this important? This will become more important to you when you get into like general surgery and ultrasound, like doing fast exams and things like that. You can appreciate what's called a rectouterine pouch, and right here, and a vesical uterine pouch, so another pouch. Basically just an anatomic dead space, and what do you think that could be important for in like pelvic or abdominal trauma? Places for blood accumulation, places you gotta go look and see if there's bleeding in those pouches. Also, same thing, not just in trauma, but in an ectopic pregnancy or any other kind of acute abdominal pain or pelvic pain, you wanna make sure there's no fluid accumulation. It's not always just blood, but if there's places for that to accumulate, and if you don't investigate that, then you might miss it, okay? Then another time if you guys get into, when you guys get into OB-GYN, this right here is sort of the rectovaginal septum right there. That's the place where sometimes cancers can grow. So a typical bimanual exam just involves 2 fingers in the vagina to assess for cervical motion tenderness and appreciate ovaries and whatnot. There is actually, a technique where you actually place 2 fingers and 1 in the rectum, and I'm not joking, it's enabled so you can actually palpate that rectovaginal septum. So, because if you don't, there's no really other way to palpate it, and you have to be able to appreciate a mass back there. And the first time I learned that was when I was working with a gynecological oncologist, and that was his standard practice, because a lot of people do not do that. And so, because they don't do that, they potentially have the ability to miss cancers that are growing posteriorly that are not appreciable. Because again, if you're doing a bimanual exam, you're pushing up against everything, right? There's no real way to trap. Why they call it a bimanual exam is because you're using one outside hand, one inside hand, so that you can track and feel things, right? So again, I'm not being tongue-in-cheek, I'm not making any kind of off-color joke. That is a legitimate medical procedure in order to be able to use and feel a tumor that could be growing in a usually non-palpable place, okay? And then of course after that, that's just to be able to appreciate a mass. Then of course after that, it would be time for a transvaginal ultrasound, so on and so forth. But just understand that that is something that you might need to do depending on your patient and her risk factors, okay? Easy enough? Okay. Uterine ligaments, we've talked about the broad ligament already. Like I said, you don't need to know the delineations of the subcategories like the mesosalpingus, the mesoovarium, so on and so forth. Basically, they're just part of that huge ligament that is holding the entirety of the uterus, fallopian tubes, and the ovaries in place. All right, but it's the major ligament that holds everything together. Other ones are named pretty well. Uterosacral, that sort of, that tells you where it goes to and from. It's anchorage points is all it really is. The cardinal ligaments help hold everything in place down at the vaginal canal level, okay? And the round ligaments extend forward. So sort of we have these planes where we have a big base ligament that holds everything together, ligaments that hold it up, ligaments that hold it out, and ligaments that hold it down, okay? And if you look here, we have an anchor point here, an anchor point here coming forward, even though you can't really appreciate it, it's coming sort of at the screen. Then the round ligaments anchoring it down, and then the whole broad ligament keeping everything from moving. Because again, you don't want those ovaries torsing, because that is a problem, right? You can't have them twisting around. And the same thing, you can't have the fallopian tubes twisting around or moving on themselves, right? Imagine if the ligament wasn't there, and this was just sort of floating around-ish in the peritoneal cavity, like say your small intestine, right? you know, if it folds back on itself or something like that, well, then you have the obvious problem of potential ischemia, but you also have the problem of an oocyte's not gonna be able to make, so infertility issues. Does that make sense to everybody? So that's why we need to have it based down and held in place, okay? So, blood supply, we're going from largest to now smallest, so we're working our way down, just so everybody's aware. So the uterine arteries branch out into the arcuate arteries and then into the radial arteries. And I'll show you, there's a picture coming up so you can sort of visualize what that means. But the ones that we really talk about with menstruation and where that source of the bleeding and the tissue come from is the stratum functionalis and the spiral arteries. Alright? Looking at this, you have the larger uterine artery that works its way into these smaller arcuate arteries. And then on this side, you have these even smaller radial arteries penetrating the myometrium. And then all the way down into the endometrium, you have this straight artery that kind of just stops here, just after the stratum basalis. And then these spiral arteries, and they're called spiral arteries because they're spiraling, and they go deep into the stratum functionalis. The stratum functionalis being the most exterior layer of the endometrium, right? Does that make sense to everybody? Okay. All right, now, cervix. We talked, yes, sir?
Sir, when we do fundus massages, are we preventing bleeding from blood coming from one of these arteries?
If you do a fundal massage, like you mean after birth?
Yeah.
No. Well, yeah, from the uterine arteries and the larger arteries, you're trying to stop a fairly massive hemorrhage. So it's not really the small arterioles, but it is the larger arteries, yeah, that are bleeding. Yeah, and fundus massage trying to shrink. Somebody's talking about fundus massage trying to shrink it back down after birth if somebody's having a postpartum hemorrhage. All right, so you're trying to stop bleeding. Yeah. So the cervix part of the uterus, we talk about it almost as if it's its own thing because it has its own problems with cervical cancer screening. So it's a unique tissue, all right? And so let's just dive into that here. So the ectocervix, this one's out to in for some reason, but we're talking about, again, the outside, the piece of the cervix that you can physically see when you do a speculum exam. Is the ectocervix, all right? The cervical canal is the portion in the middle that connects that then to the endocervix, which is the opening and the portion of the cervix that opens into the uterine cavity, okay? Cervical mucus comes from cells, columnar cells that line that cervical canal, all right? And so they're columnar cells. We're familiar with columnar cells now. They're usually mucus secreting cells. We've talked about them in a number of other anatomical locations, all right? That mucus during ovulation, because we want to create a more favorable environment for fertilization and implantation, changes pH, changes viscosity in order to make it a more hospitable environment for the sperm to be able to survive the trip and fertilize in the fallopian tube, okay? But if you're looking at here, external, again, what we're seeing on a speculum exam, and then cervical canal, and then the internal os, the opening into the uterine cavity, okay? And so this right here is what you should see if you successfully capture the cervix on a speculum exam. That's what you're looking at, okay? So what I'm saying you're seeing is the external cervical os. When you do see cervixes, nulliparous, meaning no child has passed through. That doesn't mean the woman has never been pregnant or does not have children. That means a fetus has never passed through the cervix. That could mean she was delivered in another way, like a C-section, okay? A paracervix looks more puckered and longer and elongated because a fetus has passed through there. So when you talk about cervical effacement and dilation, cervical dilation is the opening of that os, like a literal widening of the os. effacement is a thinning of the cervical tissue in preparation for the passage of the fetus through there, okay? Any questions so far? All right, let's talk about cervical histology. This is gonna have a real impact later when you talk into women's health, and you start doing these speculum exams to evaluate and screen for cervical cancer, okay? It's very similar. You guys remember talking in the GI block? You guys remember talking in the GI block about what happens with long-term GERD and you get cellular change, right? You have columnar cells in the stomach that excrete that mucus and protect it from the acid. And then in the lower esophagus, you have epithelial cells, right? Stratified epithelial cells to sort of help protect from the abrasive quality of the food that you swallow. And what happens on long-term GERD, remember we called that Z line, the Z line, like the squamocolumnar junction starts to go north. It's very, very similar to the potential development of cervical cancer, except instead of a Z-line migration, in this case we'll talk about a transformational zone, and I'll show you guys that in just a minute. But if you can conceptualize that is essentially the same physiology we're talking about now, except just in a different anatomic location, okay? It's metaplasia. You guys remember what metaplasia is? Change of a cell. And metaplasia, rapid cellular change, can eventually turn into dysplasia. Dysplasia is a type of cell that is no longer benign. It's a more malignant cell, right? It is a cancerous growth of some type, right? Metaplasia begets dysplasia often, right? What is rapid unchecked cellular growth? Cancer, okay? Exactly. All right, so that is a preface for this, like I just said, the ectocervix, right? And what is the ectocervix? It is the lining of the vaginal cavity and the outside of the cervix. What happens? There are we're gonna have to talk and be able to not laugh, you guys. Sexual intercourse is an abrasive, and when you're talking about friable, delicate vaginal mucosa, it's friable. So you need to have protective layers of skin there that can handle that abrasive quality, right? That aren't friable, that are going to be able to handle the more acidic environment inside the vagina, so on and so forth. They're going to be able to handle sort of what happens in the vagina, right? It's more external, right? Internal, we need to create that cervical mucus, right? So that is why in the cervical canal, in the endocervix, we create mucus, the cervical mucus with the columnar cells, right? Does that make sense, everybody? Right? But see, that's the thing. These cells are on the inside because they're thinner, they're more fragile, and so they could not handle what happens in the vaginal cavity, which is why we have the other kind of cells there. Anatomically protective for the patient, right? Now, we have a squamocolumnar junction, as we just talked about. At some point, the epithelial cells meet the columnar cells, and that is at a normal point where it should be. Usually, it's in the cervical os. But we're going to talk about that here in just a minute. Okay, it's inside the os, meaning it's actually inside the cervical canal. All right. The transformation zone happens as the woman ages, typically, where that old squamocolumnar junction ends and their new one begins. Just like the migration of that Z line in your esophagus, right? There's a visible area where you can see this is where the line was, but it has grown now out, and now the new line is back here. Does that make sense, everybody? I'm going to show you some pictures, but that's the concept, okay? The problem with that is not just HPV infection, but it's a metaplastic area, right? So not only is it vulnerable to HPV, which then will lead or can lead, depending on the viral strain, to cervical cancer, the metaplasia itself predisposes to potentially cervical cancer as well, just cellular change, okay? It's an area of cellular change. Does that concept make sense to everybody? Okay. So let's look at these, and these are just approximations and drawings. So these are, just to be able to visualize what I'm talking about. So premenarchal, what does that mean? Before puberty, before menarche. She's never had a period before, right? So her hormones have not been overexposed to a great deal of estrogen yet. The estrogen burden comes on, and that's what helps onset puberty. So right now, as I said, the squamocolumnar junction, the SCJ, right, is sort of interior or right at the cervical os. Does that make sense to everybody? So if you were to look, if for some reason you needed to do a speculum exam on a female that has not had a period yet, you would expect not to be able to see the squamocolumnar junction. And that would be normal, right? Okay. Is that clear? Okay. Now, you have an overwhelming estrogen burden. The cells of the cervix are very, very estrogen sensitive. Okay? So you have potentially a movement of the squamocolumnar junction out. This is not necessarily anything that predisposes this person to cancer, right? Because you see it sort of moved out here. And this, you see this word here is called ectropion. Do you see how, can you appreciate sort of, and I'm going to use the term beefy because that's what it's referred to as, sort of a beefy redness in the right immediately around the cervical os? Can you see that from back in the back? So that's cervical ectropion. What is that? That is essentially that is the columnar cells having come and grown out of the cervical canal into now the out or exterior external cervix. Okay? That is typically a normal finding, especially in a young patient, because they're exposed to high levels of estrogen. It's not anything that is specifically going to predispose this patient to cancer or anything like that in general. So it's typically a benign finding. It's called cervical ectropion. Okay? Make sense, everybody? So we're talking about early reproductive age, teens, 20s. Okay? Clear so far? Okay. Later reproductive age. Now we've got. See, in this case, the columnar cells have moved, right? But we still don't have any like real transformation zone. We just have columnar cells growing outward. In this case now, later reproductive age, longer exposure, we have an actual transformation zone. And the transformation zone is from here to here. You see outside of that, if you're looking outside, exterior to that yellow line, it looks very pink, right? Inside the yellow line, inside between the yellow line and the blue line, it looks very shiny. And then inside the blue line, you can see it's darker red. Does that make sense? Can you see that? That middle part is a transformation zone. That's the part that we're concerned about for cellular change, metaplasia, potentially dysplasia. Okay? And if you can see, I don't know how well you can see it. Can everybody see this right here? That little thing I circled, can you tell? I know red is probably not the best color, but it's there. If you're looking at your slides, it's just there's a little cyst-looking thing right there. It's called an Ebothian cyst. Essentially, it is sort of a benign cyst of the mucus-producing cells. It's sort of like a trapping of mucus production in that cell. It's a benign cyst. It's called an Ebothian cyst, and it doesn't typically cause any kind of pain or problem or anything like that. But if you see it and it doesn't look like the surrounding tissue, your first instinct should be like, what is that? That's what it is. It's a benign finding, so you don't have to worry about it. Again, you'll find out more about pathologies and interpreting this stuff later, but does that make sense? It's just a benign cyst of a mucus-producing cell, okay? This is the area, and we'll talk about how we do a pap smear here briefly, but that's the area we're worried about as far as cervical cancers in general, okay? So now perimenopause, and what happens around perimenopause? What happens to your estrogen levels around perimenopause? You guys know? They start to decline. Estrogen levels start to decline, right? So we have sort of a regression of that transformation zone in those columnar cells back proximally into the cervical canal, right? So there's a tiny difference. I'm just going to show you that. The transformation zone is moving proximally. And then if you have a menopausal cervix, you see very, almost no estrogen. The columnar cells were not producing, that patient doesn't produce a lot of cervical mucus anymore because of a very, very low estrogen. A lot of women who are menopausal experience a lot of vaginal dryness. That's because they don't produce as much mucus as they used to because of a reduced estrogen effect. And the transformation zone has again sort of moved even more proximally. So the uterus actually almost, and the cervix, the cervical os appears almost pre-menarchal. Because again, there's not a lot of estrogen at that point, there's not a lot of estrogen at this point, so they look very similar. But there's a regression. And you can see a tiny, like this is the difference between perimenopausal and menopausal. We still have all of these columnar cells. The transformation zone's still wide out here. Then you go to menopause and it's moved in, and we only have this many of the columnar cells. Does that make sense, everybody? And ultimately what modulates that is exposure to estrogen levels, okay? This is not any specific one, this is just, again, one that you can see. We look at the transformation zone. So, this is like a woman who's had a child, right? You can tell she's had a child because how? The widening and the elongation of the cervical os. And you can tell she's probably still within her reproductive timeline because you have a transformation zone and you still have some columnar cells being able to be seen, right? We're kind of moving in. So this woman is probably in her 30s, 40s, I'd say, or early 40s. But that was what you expect to see with a patient who has born a child through vaginal delivery and still has estrogen in her system. Okay? Now, as I've talked about, this is what you will see if you have a speculum, right? This is a picture of a speculum exam, and so that's exactly what you should see, except you can't really see the speculum, right? But you should be able to trap the cervix and then be able to do your examination, okay? Now, histology-wise, let's talk about pap smears. Everybody know what a pap smear is, all right? We're checking cervical cells. We're harvesting cervical cells in order to observe for any kind of dysplasia or metaplasia. All right, and there's various degrees, and you guys will spend a lot of time learning that. We're not going to talk about them here, but let's just talk about the mechanics of how a pap smear is done. So obviously, it's a speculum exam. So there are two different types. Usually what you guys will see is, in my opinion, in most cases now you'll see the cervical brush. That is sort of like a 2-for-1 tool. The longer bristles will go into the cervical os, they'll actually go into the os so you can appreciate endocervical cell, cervical cell. You see how this part is sort of curved? That is in order to, as you put those bristles inside the cervical os, they're supposed to come and brush directly up against, sort of meet the cervix like that, and you twist around, all the way around, and you collect outside cervix cells and inside cervix cells. You hand that to your nurse or your tech, they put it in a cytology medium, and that goes off for examination, okay? There's another that's two different tools, which I don't see a lot anymore, but they are still there, they're still around, so you might have to use them. The first one is called a spatula, and it really is called a spatula. Imagine sort of half of that tool, it's like a plastic spatula that's curved, right? It has a short end and a long end. You put the short end in and just sort of brace it in the cervical os, and you just run the spatula around. It's sort of firm plastic, but not like super firm, right? It's just enough to sort of brush the outside. And then you have another thing, it looks like, similar to that handle, it looks like a small end of a pipe cleaner. It's really what it looks like, you guys, because it's a brush. You put that in the endocervix, twist that around, and you give those two, and those go up. Usually, you're going to see the cervical brush because it's less uncomfortable for the patients. Okay, so one tool for two tests that's convenient for your patient, and it's less uncomfortable for them. But anyway, that's the mechanics. That's what you do during a pap smear, to collect those cells and send them off for cytological analysis to see if there's any abnormal cells. And then you take it from there. You guys will learn the interpretation of results later on. Does that make sense, everybody? Is that pretty clear? All right. Any questions about the uterus, cervix, any of that? All right, you guys, am I going too fast? We good? Okay. All right. So, we'll talk about the vagina, fibromuscular canal, obviously very dispensable, has to be able to stretch quite a bit in order to allow the fetus to pass through. Okay? So, we have the fornix, which is sort of these posterior recesses, right? The fornices are here. Let me stop being dumb and change to a different color. Oh, go back, come on, you need green. Pink color, yellow. So, whatever, this thing. The fornices are sort of these two pockets on either side of the cervix, okay? Reason why that's important is when you're examining for vaginal bleeding, you have to make sure that you examine fully and see into the fornices to make sure you're not missing any blood or anything that's back there. That's another, you can have retained vaginal substances. Sometimes you'll have women who come to you, that have a tampon that they can't get out or something else. You have to be able to look back into the fornices to see, you can't just grossly appreciate the vagina. You have to make sure that you inspect those recesses because stuff can go back there. And I'm telling you, this is stuff that won't happen when you come into the emergency room and urgent care, sometimes even to your women's health clinic. And you never know unless you look there, so you can assure the patient that everything's under control, everything's taken care of. Because vaginal, also, the other reason to look at fornices is because vaginal cancer is also a real possibility, so you have to be able to see that tissue as well, okay? The muscular, the adjunct tissue is the outside, basically holds everything down. It's part of what is contiguous with the ligaments that keep everything in place, prevent them from moving within the pelvic cavity too much. And then this muscularis is what allows childbirth to occur, it allows the stretch. There's a high degree of stretch in order to be able to allow passage of the fetus. Okay? The mucosa is continuous. Let me highlight this. Like I said, it is continuous with the mucosa of the uterus, but it is not the same. That's everything we just went through as far as the change from epithelial tissue to columnar tissue, right? Does that make sense to everybody? So don't let that bullet fool you. Everything we just discussed as far as where the transformation zone is, although the mucosa is technically continuous. Okay? The hymen is a covering of the vaginal cavity. You may appreciate this on infant exams, well child exams. Anybody who has not had intercourse may have an imperforate or a hymen in place. All right. Anybody who has had intercourse or who has had a child, regardless of how the child was conceived, will have what's called paracentroitus. So the opening, the hymen is disrupted, and they have paracentroitus. Paracentroitus technically means pregnant opening. Okay. So, but it is somebody who has had the hymen membrane has been disrupted. This right here, imperforate hymen, you see how that's completely closed? If you have a female patient who is of the age of menarche, but she is experiencing symptoms of menarche, but she's not bleeding, imperforate hymen is something that you have to inspect for to see if that tissue is still there. And it is a possibility that that will occur, all right? So it's just something you have in your bag of tricks, your differential diagnosis about menstruation problems and menarche, all right, the initial period. Breast development, other things, you said in breast development, hair development, other things are occurring that suggest puberty is occurring, but there has been no bleeding, then obviously she needs an examination to see if that's the case. It's a multitude of things that have been causing that, but that is one of them, so don't forget something like that, okay? So we're going to talk a little bit about sort of analogous structures, all right? Because we did talk about the penis and the erectile tissue yesterday. So let me ask you guys, I'm going to be done here pretty soon. You want me to just flow through? If anybody has to go to the bathroom, please go ahead. Otherwise, I'm just going to flow through the next maybe like 10 slides and we're going to be done, okay? All right. So the prepuce, what is that analogous to? It's the sort of the clitoral hood, is what you may have heard it called before. It's analogous, similar to the foreskin. of the patient of the penis, okay? The clitoris is itself analogous to the glans penis. The labia minora, these are the outside labia. They have subcutaneous adipose tissue versus the labia minora, which are immediate to the opening of the vaginal orifice. I'm sorry, that are thin membrane of tissue with no subcutaneous fat. Okay, down here you have Bartholin's glands. We'll talk about what those means. And then up here near the orifice of the urethra, you have what's called Skene's glands, which are periurethral glands. All right. So we'll talk about what all of that means here in a minute and the analogous structures. The vulva is the entirety of everything that you see as far as the external genitalia. Okay. Mons pubis, labia minora, labia majora, all encompasses the vulva, so that's what that is. All right. The mons pubis is essentially what it sounds like. Honestly, it's a mound of adipose tissue over the pubic symphysis. It's a cushion, all right? And that's exactly what it serves to be, okay? Here, the labia majora have sebaceous glands and sweat glands, okay? The labia minora, mostly sebaceous glands, okay? Not a lot of sweat glands in the labia minora, okay? The clitoris does contain erectile tissue. We'll talk about sort of the analogous structures. They have their own corpora cavernosa, just like the paired corpora that are in the penis. They have corpora cavernosa of the clitoris, okay? And we have the vestibule, which comprises most of what is external, the hymen, the vaginal orifice, right, the urethral orifice, and some of the ducts of the glands we're going to talk about. And they have a high degree of pathology associated with those glands, unfortunately, okay? So, you're going to for these, you're going to have to know both the eponymous name and the anatomic name because they're going to be used interchangeable. Most of the time, honestly, in clinic, you're going to see them called Skene's and Bartholin's glands. All right. So just understand you're going to have to understand which one is which. Skene's glands are superior. If you want to think about it that way, that's kind of the easier way to remember it. All right. And Bartholin's glands are at the bottom. I mean, again, however, whatever memory trick you have to use to understand where they are, just do it. Okay. You have vestibular bulbs, that is erectile tissue, and then you have corpora cavernosa of the clitoris. So both of these are erectile tissue. Okay. These are mucus-producing glands, both of these here. Okay. Just again, leading to lubrication for sexual intercourse, facilitation of sexual intercourse. Okay. So looking at, you have the glans clitoris, like I said, is the analogous structure of the glans penis. The prepuce, which is, again, the analogous structure of the foreskin. Looking here, you have the Skene's glands, right here, and Bartholin's glands. All right? And we will talk about Bartholin's gland cysts. Anybody have ever heard of a Bartholin's gland cyst before? Usually pretty painful to the patient. We'll discuss that briefly here in just a minute, okay? But if you're talking about the erectile tissue, so these are, again, analogous structures to the corpora cavernosa of the penis. They're the corpora cavernosa of the clitoris. The crus, again, a bony attachment, just like the bony attachment of the pelvis to the penis, right? And then you have the clitoral head here, the clitoral glans clitoris. These purple are vestibular glands, right? The vestibular bulbs, excuse me, these are the erectile tissue. The vestibular glands are the ones in green. So these are the Bartholin's glands that secrete mucus here. All right. So the corpora cavernosa and the vestibular bulbs are erectile tissue. All right. And there you see them transposed on an actual picture. These are the Bartholin's glands down here, the vestibular bulbs, and the corpora cavernosa. Okay? Now talking about Bartholin's gland cysts, they produce mucus, right? So there's a possibility for the duct to become obstructed, which is usually the pathology, and then you get a downrange you get an uprange obstruction, upstream obstruction, downrange you have static fluid, now you get a cyst that can become infected and become very, very painful to that tissue. You know, that tissue is very sensitive, and so it becomes very, very painful for your patient. It usually just looks like what you would imagine a cyst would look like, hot, red, swollen, terse, tender, okay? And so what needs to happen is what's called marsupialization. What's a marsupial? It's a pouched animal, kangaroo, right? So you create a pouch. Now the problem with creating a pouch and exposing or expressing that fluid, what's the problem there? Infection is just a dead space. Stuff likes to grow in dead spaces, right? So you use what's called a word catheter. So you express the tissue, you express the fluid that is stuck there because of the obstruction, all right? Then you place this little catheter inside. It has a balloon that you fill up with air or saline, and usually saline so it doesn't pop, honestly. And then that stays in that cavity and allows tissue to slowly grow in, okay? And it does have to remain there for a little while depending on the size of the cavity of the cyst, all right? So it's called marsupialization, and that instrument is called a word catheter. That is something that you will do. That is primary care all day, every day. So that's something, yes, sir.
How big of a cyst are we?
It depends.
It's gonna get like.
It can get big. They can be really dramatically large. Yeah. Okay. But regardless, size doesn't necessarily correlate with pain. It's similar to kidney stones, right? So a small cyst in a very highly sensitive, highly innervated somatic nerve area may cause a great deal of pain even though it is not appreciably large. Yeah. Okay. All right. Yes, sir.
For that procedure, once it's done, or it's starting to heal around the balloon, you just deflate the balloon.
Yeah, it comes out. It gets smaller and smaller. Yeah. So that you can allow that tissue. It's called healing by secondary intention. Right? You're allowing it to grow from the inside out. Anybody here has ever had even a simple abscess? Huh? Like an EIC, anything, epidermal inclusion cyst is what EIC means. So anything that takes up a large space and would leave a large cavity, you would pack it and then have the patient come back on a regular basis, remove the packing, put a little bit less in, put a little bit less in, until eventually you've got a cavity that's sufficiently shallow enough where you can just let it finish growing. You don't want to close that by primary intention. Primary intention means suturing and close, because ultimately all you're leaving is an air pocket there, right? And so that has a very high potential to develop bad stuff, right? Yep. Anybody else? Any other questions? Okay. So perineum, real fast. This is surgical anatomy. This is anatomy that the general surgeons want you to know. So that's why it's sort of just laced in here. But it's a diamond that is the pubic symphysis, the ischial tuberosities, and the coccyx. Okay? And it's because these are two important areas for surgical anatomy, the anal and the urogenital triangle. All right, and I'll show you what that means here in just a second, actually right now. So you have the urogenital triangle, obviously superior if your patient is supine. Superior is the urogenital triangle, the upper triangle. The anal triangle is the lower triangle. And there are many, many, many important structures in that area. In the anal triangle, what the real issue is down here is when you talking about perirectal or perianal abscesses and how far they might go. So the anal triangle has a lot of important structures in there. So this is good surgical anatomy, right? And then the male perineum, same thing, just different stuff in there. Okay? All right? So that's surgical anatomy they wanted us to include for you. Now you know that. So understanding the urogenital and the anal triangle, what are the borders? That's good surgical anatomy. That's a great pimp question for surgery. Okay. Mammary glands, real fast, not part of the reproductive system. Also not technically part of the endocrine system, although they could go there, but they are exocrine glands. So just 2 brief slides and then we are out of here, okay you guys? So, mammary gland. What is a mammary gland? It's the breast. The entire breast is the mammary gland. Alright? The alveoli, the things that produce the milk, are subsections of the entire gland. So 2 mammary glands, okay? Understand that. The nipple, we know what that is. The nipple contains the lactiferous ducts for milk expression. The areola is the circle around the nipple that has sebaceous glands. Alright? Those can also get inflamed and infected, especially if the woman is breastfeeding. And then Cooper's ligaments, you might hear called the suspensory ligaments of the breast. Alright, so that's the eponymous term, but usually you will hear them referred to as Cooper's ligament. Alright. The mammary gland, again, that's the entire breast. The lobes and the lobules, alright, again, just like lungs, if you will, separated into smaller pieces based on function. Okay? Prolactin, right? That's milk production, and oxytocin is milk expression or ejection. Why are they called alveoli? I don't know. Maybe they found them on the same day. Right? If you're cutting open the chest cavity anyway, who knows? But the entirety of the structure is the gland, and then you have individual alveoli for milk production, right? So each of these. So you have students or you have patients who will think that the mammary glands are these individual things, but the gland is the entire structure. And the suspensory ligaments are these ligaments that sort of hold the breast tissue up, okay? And as it says, as with age, they become looser and looser, so that's why older women typically have lower hanging, more pendulous breasts, because they lose the elasticity of those suspensory ligaments, okay? That's it for today. Tomorrow, or not tomorrow, what is it, Wednesday, Tuesday, someday? One day we'll finish this class, and then we'll be done. You guys have any questions for me? Yes, sir?
So for these triangles, you said to know the borders?
Yeah. Yeah, know what makes them. Surgeons love triangles, for some reason. Surgeons love triangles. So there's gonna be lots more triangles. These happen to be the 2 that I have for you today. All right? Anybody else? All right, thank you very much.